Well, as you know, patients with low-risk MDS, all of them are anemic. 95%, I should say, with 100% are anemic, and many of them require transfusions. About 30 to 50% require transfusions at presentation, and others along the course of the disease. So yes, we need treatments. Now we have, for about 2 or 3 decades, we have erythroid stimulating agent to these patients. They are effective, but they are effective in no more than 40–50% of the patients, and the duration of the effect is no more than 2 years at best. Since we are talking about patients with lower risk and they all live several good years, it means that many of them remain without treatment after death. Now we have already the luspatercept, which has been approved, but again, the response rate is no more than 40%. The response rate is probably 1 year, maybe a little bit more. So again, we are left with patients for whom we do not have good option. Recently, imetelstat was approved by the FDA, but still it is not approved in many countries in Europe, as well as in my country, Israel. And these patients indeed have a problem. The only one possibility after they fail or after they stop responding to these agents is transfusions. Sometimes we are trying to treat them as with hypomethylating agents, and if they have higher risk, this is not a good option. So the bottom line, there is still an unmet need for effective, easily agents that might address the anemia of patients with lower risk. A small percentage of patients have thrombocytopenia. Fortunately, relatively small percentage. Unfortunately, we do not have good agent for these patients. We used to have 2 agents which could treat the thrombocytopenia, but the development of both of them has been stopped, and currently, unfortunately, we don't have a good solution for the thrombocytopenia. So I would say the major unmet need is for the anemia after the patients do not respond anymore to these agents which I have mentioned, and in a smaller percentage, thrombocytopenia.